Brilliant, thank you. Right, so this is the first London branch meeting for 23-24. There has been some changes to the branch team since the last meeting, but I will get to that later. Before that, Catherine will go through the housekeeping for the meeting for you now.
Yes, thank you, Ramika. Thank you, Ramika. So just remember that today's meeting, the branch meetings, is for you, the members, and it's obviously led by members of AphA. So try and be as inclusive as possible, and everyone's contribution is really welcome and encouraged throughout the session. Be great if you afterwards, if you want to share on the social media. If you're on Twitter, if you could copy in the AphA Twitter account, I'm sure they'll then be able to help promote the London branch, and it helps grow the membership and raise our profile. Speakers, say thank you for the speakers we have today, but also they're also obviously representing their organisation, but they also can represent themselves as well. So that's really good. Just a few general things. If you could stay on mute if you're not speaking. As Ramiko said, encouraged to leave your camera on if you can. If you don't want to, that's absolutely fine as well. And if you'd like to introduce yourselves in the chat area, just to say, who you are and where you're from. We were having a go at forms earlier, weren't we, Ramiko?
Yeah.
Maybe for next time.
Maybe for next time, yeah.
Yeah. And if you've got a question, if you can either put it into the chat or raise your hands, it's normal Teams sort of things. I'll hand back to Ramiko.
Thank you, Catherine. Thank you. So today's agenda is this. We have great speakers lined up. We will start off with introduction to the branch leads, and following that from Ruth from the executive team. So we are the London branch leads. So as I said, I've introduced myself. Catherine is representing North Central London. Catherine?
Thank you, Ramiko. Yes, so I'm from also from Moorfields, and I'm the information manager at Moorfields as well.
Okay, and Emma will be representing North West London. I'm not sure where, Emma, are you here?
Yep, I'm here, Ramiko. Yeah, apologies everyone, I don't have a working camera at the moment, and I don't have a picture either on the slide, but I work at Imperial College in Northwest London as an analytics coach, and I'll be talking later on today about part of my role.
Thanks, Emma. And Tom from North East London.
Good afternoon. So I'm Tom Nicholas. I'm the Associate Director of Business Intelligence and Analytics at East London. This is my first AphA meeting as a member. East London, we've just subscribed our whole team to AphA. We're really excited about joining the network and sharing and listening to all the fantastic work going on across the NHS. Unfortunately, subscription took a while. My team didn't quite get the invite too soon, but they'll hopefully be joining me next round. Thank you very much.
Thanks, Tom. We're excited to have you here. And Stephen Piper is representing South East London. Unfortunately, he cannot be here with us today as he's on annual leave. But he's also the chair of London Informatics Skills Development Network, and he's the Associate Director of Business Intelligence at Lewisham and Greenwich. And Ruth, who's my predecessor, who's been the London branch lead until January, after which she stepped up to the Executive Director of Regions. Ruth.
Hi all, it's very kind of you to leave me on the slide, because I hope, although I've now got this national role, it's all voluntary of course, but this national role, I'm delighted to still be, a champion of AphA in the London branch. So and happy to support and continue to help wherever I can. So thank you for leaving me on the slide. That's kind of you.
Thank you. So we'll go to the AphA executive team. This is new team as well, isn't it, Ruth?
So some, they might not take it very kindly if I describe them as old faces. Some faces have been around for a while, and some newer faces like myself who've stepped up and taken on roles. AphA is very much, as Rumiko said, a membership organisation run by data and analytics professionals for data analytics healthcare professionals. I do want to emphasise that everyone does it on a voluntary basis. There are 2 AphA paid employees, one who does a bit of administration for the organisation, and another person, Rosanna, who does lots of other stuff, but everybody else is voluntary. Passionate people who share a vision like yourselves that we should be a recognised profession in healthcare, and given the status, and we need to represent you all effectively. And actually, I can see one of the faces. Again, not such an old face. Oh no, sorry, the executive team. You may come on to the non-execs. John's joined us. As well.
Sorry, I don't have the non-exec
No,
slide.
don't worry.
Sorry,
Well,
this was a last minute. Yes,
no, don't worry.
the latest one from yesterday.
John, do you want to introduce yourself?
Yeah.
Thanks for joining.
Hi, Ruth. Hi, Rumiko. Really good to join you all. Got you all. Yeah. So a non-executive director of AphA as well. Really passionate, as Ruth said, about the professionalisation agenda for analysts and pushing our best foot forward. But yeah, my background. Joined the NHS back many moons ago, back in 2000. Did quite a few years at Imperial, working in PCCs. Then moved into private sector with Dr. Foster, Capita, and then was very lucky to join BMJ and travel internationally for many years, seeing the best of analytics, the best of evidence-based medicine working together to improve health and care for patients. And now I'm back with working with SCW and helping the AphA team to sort of promote the agenda, as Ruth mentioned, but really passionate about some of the great work you guys are doing. But thanks for the kind introduction. Cheers.
Thank you, John. So, Ruth, I've got some data from the centre, and this is the latest data from yesterday. So this is the membership number. We currently have over 600 members across UK. So we are second after Northwest. However, this does not include the recent registrations. So I'm aware, I see Tom and Sean here, Royal Free and East London is in the process of registration. Those are not included yet, which means that hopefully London will have a boost in the next month or so. I'm aware that the Southwest London ICB is also registering as a corporate, so that would add a couple more. As you can see, in the last 10-11 months, the AphA membership for London and Northwest has tripled, and this is before those registration in train right now. And also, I understand, Ruth, that we have the 4 or 5 CSUs signing up as a corporate as well, which would add a dramatic increase, I believe, in the membership for AphA going forward. So, anything else from the AphA exec team? Is there any updates?
Shall I do just a couple of quick updates, if I may,
Yes,
Rumiko?
yes,
That's
please.
right.
Yeah.
So the first thing to say is that the professional registration process has been streamlined. There's going to be more about that on the agenda later, so I won't say anything too much about that, but I think that's helpful. AphA is really keen that we do see an increase in the number of data and analytics healthcare professionals that are professionally registered. That's how we will achieve the same journey that anaesthetists, nurses, physiotherapists have been on already, and we've got a lot to learn from their journey about how you become a professional body in healthcare. So that's key message number one. Key message number two is just to remind people about the mentorship programme that AphA runs. We're always looking for more people who want mentoring, so the mentees, but also people who are prepared to mentor as well. It's now business as usual. We did pilot it. I was part of that pilot. I mentored someone. It was a fantastic experience. I'd recommend it to anyone. But as far as I'm aware, it is the only structured mentoring program for data and analytics healthcare professionals that exists. You can obviously arrange mentoring informally, but this is the only place where it's a structured program where you can get matched with people across the country and talk to people who work in your profession and understand the challenges that you come up against on a daily basis. And it's a very, very supportive program. So I just wanted to mention that to people in case you weren't aware. And then the third thing I wanted to say was you've possibly received a communication saying that AphA is partnering with the HSJ on a conference in November in Manchester. More details to follow. They're just being worked out, but that's a really, really strong, positive partnership. You know, the HSJ is a really well-known, reputable, and long-standing media organisation working in healthcare for years and years, and quite a good recognition that AphA is growing in influence, that they wanted to partner with us. So more about that soon. And just to echo what Ramika said about the membership numbers, I think it's going to be about 600 analysts joining through those 4 CSUs. I'm not sure what that will do to the London membership numbers. It's great to see some healthy competition between the Northwest branch and the London branch. Everyone is welcome, of course, but it is also nice to see some healthy competition. So we'll need to see how that all works out in the wash. But that's a fantastic boost that will be now representing all of the CSU analysts too. That was it from me, Rumiko. Thank you for the opportunity for doing a few quick updates.
Thanks. Thank you, Ruth. So on to our next agenda. So Rachel from NHS England program for FDF program is here to do some presentation around the faster data flows. Rachel, welcome.
Thank you.
Would you like to share your screen?
Yep. I will, thank you.
I'll stop sharing myself.
And there we go. So hi all. I know some of you definitely met me before, and some people definitely not, but good to see a mix of familiar rather than old Ruth faces, and some new faces as well. But thanks very much for having me today, and thanks for the invite on that front, Ruth. So for those of you who don't know me, my name is Rachel Bevan. I'm working as a programme manager on behalf of NHS England as part of the Faster Data Flows programme team. So what I've got today is just a few slides for a bit of a reminder of what Faster Data Flows is for those people who aren't familiar with the programme, and then a bit more of a detail on where we've got up to so far, which will also include a bit of an update on community Faster Data Flows. Obviously, the focus today has been quite heavily on acutes, but I'll pick up on both, and I'll make sure that there's some time for some questions as well, if that works for everyone. So just going back to the beginning, because I think this is one of those things we can never go around enough times, but why is Faster Data Flows a thing? So Faster Data Flows as a programme was very much one of those things that came out of the learnings from the pandemic. So as everyone in this virtual room will be well aware, millions of new data collection set up obviously very quickly through the earlier and continued stages of the COVID pandemic, thinking about how we can get data more quickly across the system in a more granular level of detail. But obviously that was a very reactive set of circumstances necessarily at that point. And so it really opened, I think, national eyes to that realisation of there's a lot of power behind having that data in that way, but also recognising that particularly off the back of the pandemic, but even before then, there was a lot of data collection going on within the NHS that could be streamlined a lot more efficiently, lots of scope for improvement, and also thinking about how we can start thinking on how can we make things a bit more automated to hopefully make some of that a little bit easier for people like yourselves. So Faster Data Flows was set up as a programme just under a year ago now. That's when we had the sort of initial stages, and very much set up with sort of a dual ambition. So the first part being about that, having an automated daily flow of patient level data flowing directly out of trust PASs or trust data warehouses up into the national data platform, but then also recognising that this would be a different collection method to things that are already in the system. And again, that thing of lots going on already, we really need to reduce that reporting burden. So thinking about how we can use faster data flows to do that also. So the focus being on faster data flows collections being on a daily basis, but also having an infrastructure that supports the processing time and the whole wraparound model of faster data flows, meaning that the data flows out from providers and is available within the national data platform within, it's looking about an hour at the moment, but much faster than other collections that are out there at the moment, as often the sort of supporting infrastructure and the processing time can mean that that's where it's even daily submissions are not then viewed until a couple of days later. So having that daily level, but then it also being patient level data rather than aggregate collections, which obviously enables being able to drill down into the information in a bit more detail, and being able to play with the data, obviously within appropriate realms, but being able to play with the data a bit differently, be able to feed that back into systems in different ways, and think about how, whilst faster data flows has been set up as a national collection or a national collection method, how can the data be used effectively within providers, within systems as a whole, within ICSs, and to think about what sort of operational support there can be there as well. So very much focus on use at a national level, but then also bringing it back down to the local level as well. So we've got two branches to faster data flows. So for the first part of the presentation, I'll talk solely about acute faster data flows because we're much further along in the process with acute faster data flows. But we are also developing faster data flows for community providers. So I'll spend a little bit of time towards the end of the presentation just covering that off as well. But for faster data flows for acute trusts, as many of you on the call will know, covers current inpatients, admissions, discharges, and outpatient attendances, all data that's already collected within the system throughout other collection methods, and a much smaller group of data items being requested. But again, it's about that having patient level and then also being that quicker submission method as well. So with that in mind, we've got a few bits just to update on in terms of where we've got up to with the programme. So I'm going to cover off the first two on this slide, and then I've got another slide to cover the points 3, 4 and 5 there. So point 1, so again, many people on the call will be familiar. Back in early February, a letter was released nationally to all providers across the system, requesting that all acute providers implement faster data flows by the end of March. And a massive thank you to everyone who was able to meet that deadline, recognising it was a very tight turnaround, but we had a really great response from the acute sector on that front. So thank you very much. Also recognise that there are obviously still a few providers to implement for various reasons. If you are in one of those organisations, I would just say feel free obviously to make use of colleagues around you. A lot of people have gone through the same thing already, and a lot of issues can be resolved through that sort of peer support. But we're very much also here still as the programme team to keep supporting providers to onboard. And similarly, I'd recommend accessing the futures page, which when we circulate these slides around, there's a link to the futures page at the back of it as well. But that's where we've got all of the documentation to support you in onboarding as well, but very much do use the FDF programme team. We haven't gone away just because the deadline's passed, so please do use us on that front. So we're continuing to work across the acute sector to build up submissions, and again the next stage of that as well is also looking at, now that we've got the data flowing through, starting to do a bit of a review of what the consistency of submissions is looking like. So obviously making sure that we're working towards every provider being able to submit that data on a daily basis, not just as a one-off or sort of partially through the week. And then also looking at the data quality within that. to see how that's looking. So just linking into that, so in terms of the sort of burden reduction bit, which I mentioned earlier, and obviously data quality is sort of a key enabler within that space. But one of the things that we are particularly focusing on now, which we've been working on over the last couple of months anyway, but particularly accelerating the work through now, is around the reconciliation of metrics generation between faster data flows data and the acute discharge sitrep data. So that's the first sitrep that we're targeting as a programme team. And essentially what I mean by that work is when you go into the national data platform, once the provider's data has started to flow into it, there's a section where you can see the numbers that a provider has submitted for metrics against the discharge sitrep. So every single metric will have the last value that was entered there or for a particular time frame. And then what number is being generated through the use of faster data flows data. So you'll recall that the idea is that all the data is thrown out of provider systems into the processing and it runs through our programme business logic to then produce the metrics at a national level and taking that into, again, an automated feed. So what we're doing at the moment, we've started to see with some providers that some of those metrics are mapping up completely like for like now. So the numbers are coming out either exactly the same through FDF data compared to the sitrep data, or maybe with just a difference of 1, which is certainly within tolerance for the current sitrep owner. So we're continuing to do deep dives across providers to run through where there are still discrepancies within the data to understand, is that business logic on our side that we need to update? Are there things from a provider perspective that we need to factor in around how that's how sitreps are currently populated and things like that? So if I'm happy to take it offline, but if there are any providers on the call who are interested in supporting that as a piece of work, do just drop us a message as well. But we're working through that because one of the key things, I know that across the acute sector, naturally there was some healthy skepticism around, yes, we want to reduce sitreps, can we actually do it? But for FDF, we're very much like, yes, this has to happen. It's got to be part of the package. And so we're really keen on accelerating that work and getting to a point where we can say that we're ready to start standing down the discharge sitrep across providers, provided that certain criteria is met. But we're working across with the current sitrep owner in NHS England and also the performance analysis teams in NHS England to again work through the exact process for that, whilst in parallel developing that business logic as well. So that work is really progressing on. So yeah, do give a shout if you'd like to get involved in that as a provider. We're also recognising that that's one sitrep nationally. There'll be other sitreps nationally that we can also target, or other collections that we can also target. But we're also looking at what we can do at a local level as well. So we're working across all the desk rows to look at what local flows are in existence at the moment. How might they be able to be replaced through the use of FDF data as well? So again, recognising that there's a lot of scope here to streamline a lot of stuff that's already ongoing. Similarly, previous programmes of work within NHS England around specifically around burden reduction, recognising that obviously with the merger between NHS England and NHS Digital, there's quite a lot of work there to bring together how can FDF support within that environment and start bringing everything together and hopefully having sort of more streamlined conversations on that front. And then the final point to reference on this as well. So there's obviously the use of FDF data in terms of that metrics generation, using it for collections and local flows and that sort of thing. But we also want to be clear around what are these specific requirements from ICSs or from ICBs. How would you want to use that data as a local system? So certainly colleagues from Imperial on the call and others as well, we've discussed within North West London around what that might look like and got sign up as an ICS to say, right, this is something we want to pursue as what is one option of how we can access the data in a local system. What would you want to use it for? How would you want to get it? At what point would you want to get it? And see what we can work with there and how we can build that out for ICBs and ICSs. Having similar conversations with other systems as well, particularly where they've got quite different setups, because you recognise there'll be obviously differing requirements from different systems. So what are the different requirements that people want fulfilling and how can we build those out for the programme? So again, very much bringing that up at the moment. Similarly, whether it's other use cases or other stakeholder groups or anything like that, where you think there could be use for the FDF data, we're keen to hear about it, with the caveat of the FDF data is not yet ready to be used, but we're keen to understand further down the line what people might want to use it for. But obviously keeping that protected at the moment, recognising that there's a bit more to do around the consistency and data quality point that I brought along before. Excuse me. But yeah, again, please do reach out if anyone is interested in having further discussions on those points. So just as a final bit on community, just before I wrap up, so as I mentioned, we've still got work ongoing around community fast data flows. It's a bit of a longer journey for community, given the current status of data collection. It's quite different to data collections across the acute sector. Also recognising that there's a lot more community providers if you went out to every single community provider within England. It's not necessarily that we'll go out to every single one, because that obviously includes sort of one-man bands running where they definitely wouldn't have the infrastructure to support fast data flows, but working out what the exact scope looks like and also how we build that out for community. So we've got to a point where we've now got a data specification for community, because we've been working on that particular arm of the programme since last summer. Went through a bit of a discovery phase back then to understand the setup within community providers and what would be helpful to have in a specification, what wouldn't be helpful to have in a specification, and so on. So we've got to a point where we've got the data spec agreed, and we're working through now the IG, much as the same as we did for the acute project. And we're also now recruiting early adopters to be able to support us with the sort of initial testing around that work. So again, following the same sort of process that we did for acutes, working through synthetic testing to make sure submissions to the API can be made as they should be able to be, working through them, an initial flow of patient level data to make sure that it matches up with the processing and that PID is handled correctly and everything else, before then flowing the data into the national data platform. So again, if anyone's interested or you want to share the messages with colleagues, actively recruiting for early adopters, people are welcome to come on board for community at any point on that front. So drop us a message either now or any time in the future. I think the only other thing just to note at this point is, because of the volume of community providers and the sort of wider variation in scope as well, the rollout approach for community is planned to be done in cohorts rather than the approach that was taken for acutes, where it was all acute providers all at the same time. So there will be further communications to come through around, you know, what that looks like, who's in which cohort and so on. But that's sort of early in the planning phase at the moment. But again, any questions or queries at any point on that front, do just reach out on that front. So just, oops, sorry, I forgot there was this slide. I thought I was about to finish. So I'll just very quickly run through this final slide. So I think we've spoken a lot about fast data flows and what we're working on right now. I think the other thing to emphasise is that we anticipate faster data flows will be the starting point for moving towards this better, hopefully bigger picture of data collection across the NHS. So on the left, that kind of depicts where we're at the moment, with loads of different flows, loads of different collection methods, often quite reactive responses to things, having lots of different numbers that are all meant to be the same but different sources of the truth and so on. And then moving through to sort of this more streamlined, rationalised version of data collection across on the right-hand side. But so this is where we are for fast data flows right now. It's going to be a journey. We're going to keep going on it. It's going to be lasting for a while, but very much that sort of move into that future state over on the right-hand side there. So just as a summary, so acute providers, whether you've implemented or are moving towards implementation, just give us a shout if you do need anything from the programme team. We're still here. That's what we're here for. Community providers, just drop us a message if you're interested in becoming an early adopter or just want to hear a bit more about the details of the specification or similar. And then, yeah, ICB/ICS is, again, just get in touch if there's anything you'd like to discuss around sort of local requirements there and building that out as a use case. So I will stop sharing my screen. and see if anyone's got any questions.
Thank you, Rachel. Thank you. There are a couple of questions on the chat. William, would you like to ask a question yourself?
Yeah, sure. Thanks a lot. That's really interesting. So there's a lot of discussion of the federated data platform. I just wondered if you had any sort of how that fits in with sort of rationalizing, harmonizing data requirements, things like that.
Yeah, so I mean, I think the thing to note for fast data flows and the relationship to the federated data platform, the bit there is that so currently we've described Foundry as the national data platform, and that's what fast data flows is flowing into. When the federated data platform procurement is complete and the platform supplier is agreed, then it is presumed at this point that faster data flows would flow into the federated data platform, but that would be sort of wrapped up as a whole piece of migration work. There'd obviously be a lot of work around that nationally, and also recognising that the timescales for that are very sort of open at the moment. We don't imagine those changes would be coming into place possibly for even a year, if not a bit longer at this point. So that's kind of how FDF feeds into that wider picture within the federated data platform. In terms of sort of the other ways that that sort of harmonisation piece that you've asked about, I'm not sure I could comment in too much detail around sort of the wider FDP plans around that, but certainly I know I think the plans certainly are where programs are already feeding into Foundry. If it was no longer Foundry that the platform was based through, there would be that sort of whole migration plan. And I think only as it starts to get further and further through will things become again more streamlined, because everyone will kind of be working into that one platform. But I'm not too close to the details on that front, I'm afraid.
Okay, thanks.
Thank you. Thanks. The next question from Ruth. I think many of us have the same question. Ruth, do you want to mention this?
Sure, thanks. Hi, Rachel. Nice to see you, and thanks for coming. So my question was similar to kind of, you've already touched on it a little bit, and I'm absolutely recognising my cynicism here. I've been around for a while. I've heard of several initiatives that are going to reduce the burden, and all that ever seems to happen, or it certainly feels like happening, is that the data burden on the provider organisations in the NHS just seems to increase. And particularly over the past 2 to 3 years, actually, it feels quite exponentially out of control. So when faster data flows came along, I was both pleased and slightly cynical in equal measure, I think it's fair to say. But what would really inspire an old cynic like me would be that success story. And I just wondered whether any of the pilot organisations had achieved that decommissioning, or were at least ready to decommission any of the sit reps. And just I'm sure that the faster data flows program wanted to complement it on its comms. The FAQs, etc., were really, really helpful for implementation and the availability of information. So I'm sure you have a comms plan in this space. I think it would definitely be good to give us some success stories and inspire the whole community to do this.
Yeah, absolutely. Thank you, Ruth. And I would be disappointed if we were on a call together and I didn't have the healthy balance of enthusiasm and cynicism. So no, but you are completely right there. And I think, you know, you said it, others on this call have said it, others in London, nationally, it's going to come up, because as you say, I know that whilst it must be great to hear, they're like, oh yes, here we are. There's probably also that, oh my gosh, here's another person coming in and being like, yeah, they were going to do this, and are you really going to do it? And so I think the positive, I think from your perspective, is that obviously we've got all the providers looking at us to say, come on then, you've got to make this happen. We've similarly got Julian Kelly and IOP we report directly into saying, come on, you've got to make this happen. So we are really like, okay, we've really got to make this happen. That's half the thing with faster data flows. And I think we needed some more of the data to be flowing into the national data platform for us to be able to look at it and go, right, is this a provider specific issue in terms of these numbers aren't matching up, or actually is this consistent across a number of providers, in which case it's probably our logic that we need to look at. So there was an element of, we'd been doing some of the metrics work with some of the early adopters, but we needed to have a bit more of the data flowing through, and that was partly the push on that 31st of March implementation deadline, because it was like, right, if we can get the data in, we can accelerate the work more quickly. So we're not yet at a point of having a provider ready. However, we are very much being pushed, and correctly, that this needs to happen, within the next few weeks latest. So we've very much got that work ongoing. We've got the deep dives with the providers, and similar to you, there have been providers who've said, we've gone back to specifically because they were very much like, well, you told us this was going to happen, so we want to help you make it happen, which is obviously really positive. But I think also recognising that part of it, I think, is also a cultural thing within NHS England, because it's recognising that actually they need to also want to be able to stand this stuff down, because the worst would be that we stand it down and then it comes back up, or we have providers sort of forever dual running or something like that. But I think the really positive bit there is that the current SITREP owner and then the people that they report into are very much like, we really want to get rid of the discharge SITREP. This is the way that we're going to do it. So I think everyone is on board of like, right, we've got to make this happen. And some of that bit around sort of the ICB usage as well is understanding where commissioners and local systems use that information currently in SITREPs to make sure that then similarly local flows aren't then stood up in response to a national flow being stood down. So we are very much cracking on as quickly as possible as we can. And you're right, Ruth, as soon as we can get someone stood down with it, we will absolutely be shouting from the rafters to say, look, we have managed to actually do it, and come and get on board with that. But yeah, so it's very much in the works, but it is one of our absolute top priorities for the programme.
Thank you. I just wondered if the first lesson that might be learned is in NHSE, the quite low baseline of NHS data quality may be learned first. They may think this might have been perceived as a quick win, but they might learn it's harder than it looks.
Yeah. Although saying that, certainly some of the submissions that we've started to see are looking, I think, probably better than people expected, but they're looking, but for some providers they are looking really, really strong as well. So I think we've definitely got a view of, if we can get the logic right and the sort of rationale behind it all correct, then there are definitely providers that would quite quickly be able to move into that space, which is really positive, and as you say, will help with that. Look, this is possible.
Thank you. Catherine?
Thanks, Enrico. Yeah, thanks, Rachel. I just like to say thank you to the team for the documentation. Was really did help, and also when we did have queries, they came back really quickly, and it's gone really well. I think now where we're at is I've gone back this week and started looking at what we're submitting and where the gaps, where it wasn't quite so good. So hopefully that'll improve. Obviously, we're a specialist trust, so we don't do the discharge SITREP. I think we were very keen on the UEC part.
Yes.
So that would be something. I think I'm sitting here thinking actually we can start even from our end, maybe sort of seeing, let's compare the numbers for. But sort of, it's for a two-part question. One is, is the UEC next? Is that on the list? And thinking on that, are there plans for other data sets for the acute side to come in? I was just thinking, I was surprised very much that A&E wasn't part of that. I know we put in ECGS every day, but the UEC feeds through attendances and the 4 hours breaches. So that was my only, are there plans, at some points to expand the list, really?
Yeah, definitely. And thanks very much. Sorry, I also meant to say thanks for the feedback, Reece, and similarly, thanks, Catherine. I'll definitely feed that back to the team. But yeah, absolutely. So yeah, in terms of the specific SITREP, so yes, the UEC SITREP is on our hit list. I know that we need to do the sort of aggregate part of that is not currently collected through FDF, and that's where we need to do a little bit more work to then add that stuff in order to enable that sort of full matchup. But it's definitely been agreed as it will be part of the hit list. So hence we've started with the discharge SITREP because it does fully map. However, that will be coming down the line later as well. But yeah, for the other sort of, as you say, more broadly, there's certainly a review for other sit reps there are, particularly as you say, where things are on a daily basis, but perhaps through different collections. And similarly, particularly focus on what other aggregate collections are in place nationally to think about, okay, well, we've got that flexibility through using the FDF data because of the timeliness and because it is patient level. So actually, what could we do? And very, very timely question, because we had a conversation with a couple of people in NHS England this morning who look after essentially all the aggregate collections, and they are now going to go away and do a massive review against our spec to say, right, what's covered, what could be covered now, what could be covered with a bit more stuff added into the faster data flow spec, and then what stuff's further away but actually could still be in scope for later. So yeah, it's very much, as I said, this is in a terrifying and exciting way just the beginning for faster data flows, because we do also want it to be, you know, the ideal and sort of gold standard which we want to work towards is that not only what's already in the system, but if someone said, oh, we suddenly now need to start collecting this, okay, so use faster data flows for it rather than introducing a different collection method again, or have it using faster data flows instead of introducing a new aggregate collection. So yeah, very much at the beginning. But yes, big plans. And yeah, the A&E data has come up a few times, so it's on our sort of constant feedback list to the national teams around yeah, sort of experiences from a provider side and what could be helpful from a commissioner side on that front as well. So yes, definitely much more to come. So watch this space.
Thank you very much. Thank you.
Thank you. Is there any more questions for Rachel? I think we can just go on and on talking about this, but Rachel, thank you very much. I'm mindful of the time, so I'm going to the next session. But if there's anyone who needs more information, please do reach out to Rachel. And I'm sure we'll be talking to you from my trust as well. We're sure. Quite behind on that one. Yes.
No,
thank you.
Thank you.
Thank you. So our next session is, I'm going to just try, is the change in data culture at Royal Free, and this would be presented by Sean, Head of Information Reporting at Royal Free. Sean, would you be sharing your slides?
Yeah, thank you. Hi, everyone. So yeah, I'm Sean, I'm Head of Information Reporting at Royal Free. This is my first time joining this meeting, just joined AphA, well, just now actually. So I just got the registration. And I was invited along because I've been meeting Catherine and Ramiko before, and to talk about some of the work that we're doing at Royal Free about trying to change our data culture. So I'm just going to try and share my screen. You see that?
Yep.
Correct. Okay. So to give you a bit of background, the data culture at Royal Free, like many trusts, I imagine, is varied. There are some examples of excellence, but in pockets, but variation across the data literacy, user engagement, and examples of lack of trust in the data provided in some areas. A comment in our data strategy or a digital strategy from one of our stakeholders that we are data rich, but information poor. We sought to understand the issues and the barriers being identified in our data culture and provide solutions which could build us to become a more data-driven organisation. So just to give you an idea of the information management structure, so at a very high level, so the information analytics, we have an information management team which sits under the Chief Delivery Officer. We moved to be under him we moved from IM&T last year, about a year ago. We also have a performance and data quality team and a clinical pathways group, which is or clinical practice group that does a lot more pathways analysis and gets involved in much more clinical information reporting. But we all try to work together, and this was intended to kind of improve that. And we recently reviewed our digital strategy as well, and that was reviewed in April 2021, and data was added as a key component in data science, listed as one of the 5 pillars of the strategy and the vision. So the roadmap included to develop a curated, structured data repository So having a clinical data warehouse, essentially, and there has been some progress on this, but there's still work to be done. There's a clear data strategy has been developed. That was developed in 2021 as well, and we're reviewing that currently as well. But that came out of this to review our strategic, clinical, and business needs. And so the roadmap to 2025 looks to build on that and move to more predictive analytics, which I'm sure that a lot of people have been talking about at their trusts as well. So as part of that, we set up and to facilitate the implementation of our data strategy, we set up a data steering group. So that's been very useful to set up discussions around the oversee the implementation of the trust data strategy. So and focus on these areas too. So having data culture, consolidation of reporting, clinical coding being a focus and discussed in that way, and understanding risks and to start pushing the future data science and research and AI in innovation, which we're trying to do. So as part of that, we did an initial baseline assessment of our data maturity, and some of the things that came back were that there was a need for our alignment of the business unit. So when I say business units, that's how we split our structure. So we have the Royal Free Business Unit, Barnet, Chase Farm, and Group Clinical Services. They kind of report into business units that the divisions and specialties sit below. We have business partners exist, but then there needs to be some development of that and engagement. And we have a lot of standard BI dashboards available, but still a large number of Excel reports. And it's not very clear where you go to for information a lot of the time. And it does feel like the bandwidth for the information team is thin for the size of the team that we have. That's a comment. There's also report duplication across the different teams that I mentioned earlier. Or examples of local reporting. So people getting the data and producing their own analysis because the bandwidth for the team that hadn't allowed them to do that. There's a lot of clinical information available because we implemented an EPR in 2021 that was an upgrade to our Cerner system. So we went to Millennium, but it can still take a long time to get this data. It's not really clear what data is available because there's just so much of it. It's the main thing. But having a process for getting that information and knowing when you're going to get it is quite difficult sometimes when it's clinical information. So as you can tell, we're very much on the first steps of our journey to transform our data culture. But these are some of the steps we've taken so far that I wanted to share you and things we have planned. So as part of changing our data culture, we recognized from our data steering group that we had all of these ideas of things that we would do to change our data culture, but actually implementing them is often quite difficult. So we set up a working group, a data experts working group, which is open to anyone to join. It's the invite list is huge, and we get quite good representation from across the trust. And what we do is we use it to create a community of practice. So you share developments in data science, predictive analytics in more detail, but also to improve data literacy. So one of the things that we've been doing is talking about apprenticeships. So we've been speaking to a company called Multiverse, who have been in touch with a number of other trusts as well about reviewing our data apprenticeship scheme. And that's not just for people that are analysts, but also people that are there is like a lower level data technician, which is still a time commitment, but it's something that can be done if you're not an analyst per se. And then one thing that we recognized, as I mentioned, was around having data literacy. So as a key focus point, and we've set up a group within our team, another group, to implement the actions that we've come out of these steering groups. So it kind of cascades up and down. And what we've done is we've we're developing a data literacy webinar. So it's something that's an initial introduction, and having short segments that are led by certain people within the team to describe and explain a bit more about where data comes from, but also how you can request it. So it's a publicized process how you can get information, but you would have to go looking for it. So to have that available and to create that engagement by putting the information out there in a form that people can digest in the form of a webinar. And yeah, so other things like using data to improve performance, which we've done through comms before, but this is something a bit more that we're doing on our own. And then one big thing that came out of this was the quality assurance. So we recognized that in order to change our data culture, we needed to build the trust in the information that's provided in the first place, so that they can start having these discussions around the data. That's not just whether the data is correct or not, it's what it's actually telling you. So one small thing that we're doing is just having reports QA'd by another member of the team before they go out, and then indicating on that was who this person QA'd the report, they quality assured it, they're willing to put their name against it before it goes out. And we've also set up working groups in the key data areas, so like theatres, cancer, ED, inpatients, and maternity, and in areas that there was traditionally a bad data culture, or it needed improvement. And in order to, so we use it to be good, to basically to drive the engagement and use of the Power BI apps that we're developing for these areas, but also to feel like people are getting what they need from the app, that it's answering the questions that they're proposing, and that they are they feel like they're getting things actioned, and you know, the information team are providing what they need, essentially. So that kind of leads us on to engagement. So one thing is about improving our reputation, so assessing ourselves and critiquing ourselves and looking at ways that we can improve. And one thing that some of you may know about is the informatics level 1 accreditation for excellence, and we've submitted all of our evidence for that now, and we've got our assessment next month. So but we're also developing a royalty-free data dictionary. So what I was saying earlier about us having all of this information but not knowing where it is having that catalogued, and so people can go in and search for a field, and it will tell you what table it's in the data warehouse, what it's used for. So it's a big piece of work, but it's something that's, you know, in terms of documentation, it's going to be invaluable, I think. This picture here shows our reports catalogue that's on Power BI, and that shows just our key reports at the moment, but we're expanding that to all of our reports. And we've also started weekly data drop-in sessions, so to give requesters a chance to discuss their request in a bit more detail, instead of submitting a request that's a bit vague and for us to have a lot of correspondence back and forth, we get to have a chance to have a discussion about it. So I've spoken a lot about Power BI, and I just wanted to talk about some of the things that we're working on in our rollout program for Power BI at the moment. So one thing that that we wanted to focus on is the areas that we've implemented these reports. So theatres performance, ED, outpatients, and we have an integrated board performance app, which this shows, and I'm going to show you a bit of an overview of it as well, but it contains roughly 200 metrics, and it covers the governing objectives and all of the CQC domains provided from a number of sources, including workforce and the risk and safety team as well, so not just coming from the data warehouse. So this view gives you the opportunity to view the app in the governing objectives domain, so in a trust scorecard showing you how many are meeting the target. So you can filter this for business unit, site, division, specialty, and we have this standard template in all of our apps, so it's very familiar. Once you've learned how to use one, you can pretty much get a hang of all the others as well. And this next view gives you the opportunity to view 6 key metrics, and those are set depending on your business unit, and that you can change them, as you can see from the drop downs just above the charts as well. You can change them, but you can default them. So when you select your specialty, for example, it would default to the ones that you've set as most important. And you can drill into detail. So this metric detail page, you can drill in and you can see like an SPC. It's not shown on this one, but you can see an SPC chart if you need to. There's also comparisons, so you can compare a number of metrics, and domain visual, so you can have like a 9-page dashboard essentially, so that you can see all of that. And I guess what this is intended to do is to have one source of the truth where you would go to get this information, and we're trying to reduce the areas people producing performance packs and spending ages putting them together, and that whole manual process that we're all probably very familiar with. And then, so these are some of the others. We've got theatres, e-performance, outpatients, cancer, RTT. They are developed, but they're being redeveloped into this format. And it's worth saying that we've also, so Catherine and I, we meet monthly in a NCL business intelligence group, which we initially set up as a way to learn from what BI tools you're developing, and it's kind of developed into an extra thing of the information working group that meets every week, where we get a chance to talk things in a bit more detail, and similar to what we're discussing here. But it's been very helpful in us getting inspiration and answers to a lot of these questions of how we're developing our Power BI apps. So the next step, so I spoke a lot about consolidation of reporting. There's still a long way to go with that. There's a lot of churn and time dedicated to low priority work. And we've set up a prioritization matrix to help us prioritize things. And when people make a request, they tell us, does it have a financial impact? Is it for an internal audit? Is it a mandatory submission? So that we know these answers before we prioritize it, and we can tell you, okay, it's going to, based on that, we can give it to you in a week, or that's probably going to take 2 weeks based on other priorities. We're also setting up a ad hoc reports catalog, so you could, similar to that reports catalog, but you can go in and see ad hocs that have been developed before, so that you can see, oh, that's been done, I can just use that, or I just need this one updated, which is a lot easier for us than figuring out if someone's done it before. And this is what I've done, is we have a very high level ad hoc analysis that we do at the moment, where we look at all of the reports that have been requested on Freshdesk, which is our IT service desk essentially. And this increase that you're seeing is partly due to us being better at recording, but it shows that the spread of what kind of requests we're getting, how many we're getting a month. It's probably not the full picture yet, but what we're hoping to see is this come down as we start to roll out our Power BI apps, and that people know to go to Power BI instead of making a request. As I said, we're working on a clinical data warehouse. We have it set up. It's just that it's the platform for engaging with it that we're working on at the moment. That's going to be put into Power BI. And for it to be given access for clinicians, but it's kind of something that we're working on training and whatnot at the moment. And also to create a clear process for requesting data items to be added to the data warehouse. There's very much a process. You request it from Cerner, and it's prioritized, and then it could take quite a while for that information to come through at the moment. So, and also to apply a prioritization matrix to that as well. We've been working with Cogstack, and we've just put in a business case for that to be used to populate our COSD cancer audits, which we've got funding for. So that's going to be the first time that we're using that. It's like essentially a data mining tool, which is a very good way of getting information out of what's been recorded in the notes, essentially, instead of it being recorded in a field, which is obviously not. There's a lot of information recorded in the notes that would be useful in terms of defining a cohort of patients for research purposes. So so we want to move to more predictive analytics, and we have some things set up in Python and R through Power BI, but we've been working with companies, one called Faculty, that have been working on the AI tool for us for admission prediction through ED, which is like an internal thing that we're working on at the moment, and through Beamtree, which is a predictive analytics tools, but more to show us what's the art of the possible, because we have a lot of things that we're learning as we go, and I guess a lot of these things, you can join the R community, AphA and things like that, and ways to find out more, but it's the actual practice of doing it with your own data which is quite difficult, we find a lot of the time. And then just to say that we've had a lot of positive feedback on the progress we've made so far, and the focus shifting from that bad data culture to a good one, and demand has increased as a result of that, but we're able to point people to we're able to apply these techniques that we've implemented so far, and engagement and data literacy has improved from what we've seen so far. So yeah, that's kind of what an introduction to what we're working on at the moment. I'd be interested to hear comments or suggestions or other success stories that people have had at other trusts, or just comments on data culture in general. Thanks.
Thank you, Sean. That was brilliant. So there are quite a few comments. I think everyone's really interested in this topic. Who's the first?
I'm happy to jump in.
Yeah, sure.
Hi, Sean. Nice to see you. It's been a little while. I was interested in terms of providing data for research. Do you do it through the same mechanism, or is there a separate process for that?
Yeah, and that's a problem we have at the Royal Free. You're a lot better at it, gosh, from my experience, is that the resource is very much dedicated to the operational, financial, that's the priority. We have chief medical information officers, which are kind of like they're clinical, but they're data scientists essentially. But there's only 2 of them that are for the whole trust that get involved in the research element of things. So we prioritize things as we can to help with audits and the just information for research in general, but it's something that really needs, in my opinion, development in terms of and providing that data platform is kind of a first step in kind of helping with that resource. I think is basically.
Okay, thanks.
Thank you. And a comment from Emma. I think in Imperial there's a similar program of data literacy in the organization that Emma did a presentation in the last session. Emma, is there any comments that you'd like to add to?
I was just going to say it's really nice to hear that other organisations are also focusing on data literacy. And the comment that I just made is that sometimes the key to unlocking people's understanding of data is actually helping them understand their contribution. So kind of that whole process, as you said, kind of that end-to-end, what they do with the patients at the bedside, how that then adds up to these overarching kind of performance and KPI metrics. Sometimes that's enough to unlock that little light bulb of actually, oh, now I understand why you're asking me to put this data in the system in this particular way, and now I can understand how that number comes to be that is on this dashboard, and now actually I know what I can do with that data going forward. So yeah, it's just a well done, and wish you the best of luck going forward.
Yes, really exciting. And Ruth, the big question.
Thanks, Sean. So much of what you said was resonating. I think we're all on various stages of the journey you described, and I don't think any of us have really cracked it fully and comprehensively. Yeah, as Emma said, wish you the best of luck on it. I had a couple of questions. The first one was, without probing too much into your internal politics, because we've all got it, I just wondered what was the driver behind moving the analytics and information team from CIO, I presume, to the CDO. That debate, you know, it's a debate I've been involved in several times before, and I'm not really sure what the best configuration is really. The underlying issue for me tends to be too much demand and not enough capacity. And unless we fix that, I'm not sure it matters where we sit, but I'd just be really interested in the Royal Free perspective.
Yeah, I guess the main thing is aligning with priorities. I think is the main thing, because essentially the business units report into Pete, who's the chief delivery officer, and their comments were in the digital strategy that what we produced struggles to keep aligned with that as part of it's obviously has a lot of benefits as part of being I'm part of IM&T in terms of technical support and you know the challenges that we have with systems and things like that. So, and I've the same as you, I've seen it go both ways, you know, from operational to IT and back, and yeah, I think there's a case for both, but I think it's definitely helped us in our alignment with priorities and making sure that a lot of the things that we're trying to do, we get support of from an operational perspective.
Rebecca, I'm happy to go with my second question, or do you want to give someone else a chance, or shall I go for it?
Go ahead, go for it.
So, Sean, so the Royal Free was talking about being a hospital chain, wasn't it, before anyone else was really thinking about it too much, certainly in this neck of the woods. I think maybe up north they were a bit more mature. And now acute provider collaboratives, community and mental health provider collaboratives is becoming the norm, really. And I just wondered if there's any lessons learned you can share. So forgive me, I don't know how long you've been at the Royal Free, and apologies if it's an unfair question. And do you all have a common infrastructure? Do all the sites use the same data warehouse, for example? Because we're certainly grappling at the moment with Excel spreadsheets to try to produce a coherent. Don't judge us. It's just where we are.
No, I mean, yeah, as you saw, we're not in too different position for a lot of things that we produce. Yeah, I think we are all part of one team now. We have. I mean, I've not been here that long, since the start of last year. But as part of that, we all have access to the same data warehouse. There are still legacy things in terms of critical care data, for example, is very much one system for one and one system for the other, but it all eventually gets into a report hook by crook. And I think that the issues that I've seen are the lack of standardization across the sites or the business units. And what we've tried to do with these working groups is have them that it's one for all. So instead of saying, oh, we want Barnet, we're going to meet with Barnet, and there is resistance to that. You know, they would say, oh, we do it differently, but you shouldn't be doing it differently. So it's not in that kind of blunt way of saying it, but trying to kind of create that engagement and have people, because what we found is they learn from each other very well in the different ways that they do things, much like we do with talking to other analysts from other organizations, that there are benefits to working as a multi-site, or you know, as a group. It makes some things more difficult, but it definitely, if you persist with some of these things, then it does make a difference. So yeah, in my time here, that's the main thing I've taken from it.
Thank you. Ruth, is there any further?
I mean, I could go on, but I won't, but thank you.
Yeah, time is pressing. Was there any further questions? I'm just looking through the chat, but I'm not very good at doing this. Is there anyone else who'd like to ask questions? If you can raise hands. This is really exciting area, and yeah, we might come back to this, Sean. This is really interesting, and thank you for your presentation. Thanks.
Thank you.
Right, so our next agenda is professional registration by Emma. We're going to skip the quiz or not. No, yes, we're going to skip the quiz, so we still have time. Please go ahead, Emma.
Thanks, Rumiko. I will try and make this quick for everyone, so we might get a chance to get to the quiz at some point. Anyway, just to briefly introduce myself again, for those of you who weren't here earlier, my name's Emma Spencer. I work at Imperial College Healthcare NHS Trust in North West London. I'm one of the London branch deputy leads for AphA. My role at Imperial is an analytics coach. So part of my role is responsible for developing data literacy in the trust, hence the interest earlier. And the other part of my role is around helping my colleagues with their kind of personal and professional development, mentoring, coaching, all that kind of stuff. So AphA professional registration fits nicely into that. As Ruth said at the beginning, the process has very recently changed and been streamlined, so there might be a couple of things on these slides that might be a little bit out of date. I'm hoping my AphA colleagues will be able to add in those bits and correct me as we go through. One of the questions that I get a lot from people when I talk about AphA professional registration is, why should I be looking to do this? What benefits does it have to me as an individual? And personally, I see it as it's a chance for you to have your skills and experience recognised by an independent third party who is accrediting your skills and experience, essentially saying that you're able to do what you say that you can do. So from a personal perspective, that is, for me, I have quite big imposter syndrome, like a lot of people. I don't really believe that I possess the skills and experience that I supposedly do, and it's always nice when someone else comes along and says to you, actually, yes, you can do the things that you say you do and are on this piece of paper. Like it's just adding to your sense of self-worth. From a slightly more professional perspective, it also means that if you are, say, applying for a new role, it's quite a competitive environment at the moment out there. If a recruiting manager sees that you have been professionally accredited with a professional organisation, that gives you an advantage, because it is that third party saying this person can do everything that they are saying they can do in their application and in the interview. And having been a recruiting manager previously, you always kind of have that, yes, this person is saying all the right words, but not until they get started in the role do you actually get a sense of, can they do everything that they've said that they can do. So that's just my kind of reasoning behind why I personally would be looking to go through professional registration. I'm sure other people have many different reasons, but for me, those are kind of the two big benefits that I can see from going through this. So what does this look like? Well, we actually have 5 different levels that you can apply for professional registration, even though it says 4 on the slide. The 5th level is kind of the entry level. It's associate level. You don't really have to fill out all of the application forms like the other 4 levels mentioned here. It's more of a kind of, you're signing up to say that in the next 12 months, at some point, you will apply for one of these levels of professional registration. So it gets you on the register, but you still have to go through the whole process at some point in the next 12 months. So hence why I just say that there are 4 different levels, because you're still going to have to do one of these anyway. They start from practitioner to senior practitioner to advanced practitioner and finally leading practitioner. And the key thing is that you pick the level that you apply for. So it's not someone coming along saying, you know, I get people at my organisation saying, which level do you think I should apply for? It's not up to me to tell you. It's up to you to do the work, to read through the applications and see where your skills and experience best fit. There is an opportunity in the application process, if it's felt, once you submit your application, if whoever's assessing it feels that you might have misjudged, so whether you applied for a level that maybe is a bit above, you don't quite fit all of the criteria, or if you applied for a level that maybe is a bit below and you're showing in your evidence that actually you possess the skills of an advanced practitioner, but you've only applied for senior practitioner, for example, you'll get that opportunity to resubmit. But the key message here is that you get to pick which level you apply for. The only piece of advice I would give is that very few people on this call are probably at the leading practitioner level. The other thing is that some people ask about, do I have to start at practitioner level and then in a few years' time apply for senior practitioner, advanced practitioner, work my way up? No, you don't have to do that. If you are already think that you're at senior practitioner or advanced practitioner level, then feel free to just go straight in and apply for one of those. So what does the application actually look like? Well, the first thing, and the thing that is probably the biggest stumbling block for a lot of people, is you have to complete at least 3 what we call reflective practices, which essentially is you critically evaluating projects and pieces of work that you have completed. This kind of idea around what you did, why you did it, what you do differently next time, kind of justifying why you made the decisions that you made to complete that piece of work. The other thing that people find a bit difficult to get their head around is the idea of projects. When we talk about projects, we're not just talking about things like I rebuilt my entire reporting infrastructure for my organisation from scratch, rebuilt a data warehouse. Yes, those are quite big projects. Yes, I could use those, but actually being asked to build a new dashboard for my tissue viability service is also an example of a project that I could use for this. And in the template, it kind of leads you through those questions about setting out the situation that you were in, the tasks that you completed, kind of how you achieved those tasks, what the aims were, and then this, as I say, this kind of critically evaluating and justifying the decisions that you made. Once you've done those, and as I say, you need to do at least 3 of them, then you get on to the actual kind of standards for professional registration. So again, as Ruth said, we've streamlined this recently. So it used to be for practitioner level 49 separate criteria, and now it's currently 25 separate criteria split across 10 standards. And these standards cover a wide variety of things, from analytical approaches, AphA code of conduct, organisation and planning skills, collaborative working. So it's not just technical skills, it also looks at everything around you that makes you a good analyst, a good person working in analytics. And I've got some examples that I'll go on to in a minute. And then finally, you can submit your application whenever you're ready to submit it, but the board meet once a quarter. I have lost track of what the dates are, so I'm hoping one of my AphA colleagues might be able to put it in the chat what the next deadline is, but that is kind of the process. So you fill in, you complete your 3 to 5 reflective practices, you write your evidence, write your commentary for your 10 standards, provide your evidence and submit it. Sounds really straightforward and really simple. So let's look at some of the examples of what the application form looks like. So it starts off with the basics of essentially your CV. So you write a little bit of a profile. If you're on LinkedIn and you've written your bio bit at the bottom, at the top, then that's pretty much a replica of what you would put here. Talk about any publications that you've been involved in, list out your formal qualifications, and then talk about your career history in analytics. After you've done that, we then start going on to the standards. So I've purposefully picked one that isn't an analytical kind of skills standard. but they all are set out pretty much the same way. So you get a statement at the top telling you what kind of things people are looking for in this particular standard. So we're looking at collaborative working, and we want you to be able to demonstrate your ability to consider the needs and requirements of others, particularly in relation to equality and diversity. So there's like lots of key words at the top here. And then we have 2 different criteria for this standard. So you'd read through the standard, you'd write your commentary here about describing a time when you have worked on analytical tasks with other people in your team or different departments. This is, again, that kind of collaborative working, examples of where you've worked collaboratively. And you would then indicate if one of your 3 to 5 reflective practices also demonstrates when you've worked collaboratively with people. So you would just say which reflective practice you're referring to here, and you could use that as evidence. If you have other evidence as well, you would then label that here. And basically all of your evidence is kind of an appendix to the whole application document. So you don't feel that this is a teeny tiny box and I need to put in all my script or all my screenshots and everything in this box. You just put all your evidence at the end, give it a label, and then just put that label in the box here. So that's an example of what some of the standards look like. And then, as I say, you kind of put all your evidence in the end of the document as appendices, and then you fill in the matrix to basically just as a double check for yourself that actually, yes, I have got evidence for each of the standards. So this is, again, listing out some of the different areas of things that are assessed in the application process. So, you know, as I say, we have collaboration is one of them, but also kind of accountability, autonomy, managing your workload. So it's not just technical skills, it's the whole package. And then, yes, you would list out where your what the labels are for your evidence, and then if you're using any of your reflective practices as your evidence against these standards, that's where you would also just indicate that on here too. Finally, I've got some top tips. As I say, I've kind of helped people through this process a lot. So the first one is that evidence doesn't need to be pages of script. This is one of the things people kind of are a bit worried about when I've kind of been talking to them through this process. Sometimes you can think outside of the box. So if you are looking at trying to demonstrate your organizational skills, you know, maybe it's a screenshot of your Outlook calendar where you block out time to complete those regular reportings. You've got those deadlines in your calendar. Someone can clearly see that actually you are organising your time. And you talk about why you do that and how you do that in the commentary, but that could be some of your evidence. It doesn't just need to be pages of script, screenshots of dashboards. You know, sometimes it can be lots and lots of other things. Pretty much anything can be evidence, including your reflective practices. As I said, start with your reflective practices because these can be used as evidence. And also, this is the bit where people do struggle. And I find just getting your head in that headspace of reflecting back through writing these 3 reflective practices actually will help you then complete the rest of the form a little bit easier. Another top tip and another thing that I've had people question me about is, you know, don't be afraid to repeat yourself. There is some overlap between some of the standards, not quite so much in the new versions compared to the old versions. There was lots of repetition, but you can use the same evidence for more than one standard. And it might be that something you've written in your reflective practice, you can just copy and paste that into your commentary for one of the actual standards. And that's it from me. Very, very quick run through of what it is. I'm not sure if anyone's got any questions or anything.
Thank you, Rachel. That was really useful. Any questions for anyone? I couldn't get the date. I know I've seen it somewhere, but I can't find it. So I'll get the dates and circulate, or ask the AphA office to circulate that later on. Any other questions for Rachel? Oh, Emma, not Rachel. Sorry, I'm confused.
It's okay. Anyway, I'm used to be called by lots of different names.
Lots of names. Sorry. Any question for Emma? Okay, so I'm going to wrap up in the next 4 minutes. Just for some notifications, there is a data-driven inclusive elective recovery summit on the 24th of April. That's in a week's time. And Florence Nightingale Award for Excellence in Healthcare, that entry deadline's 1st of May. Health and Care Analytics Conference in July. Just really quickly go through. That's the session for next Monday. It's 2.5 hours. And that's the Florence Nightingale Award data entry deadline 1st of May. Tom, I believe you were the winner of last year's award. Anyone who's interested and needs some tips, contact Tom. And Health and Care Analytics Conference in July, and you can register for this on the website, and I will circulate this information later. All this information, majority of these are in the AphA magazine. When you register to AphA, you have access to the magazine. This is the latest March issue, and you can go through that to find all those informations, awards and conferences. So thank you very much. I welcome any feedback. If you have any ideas on topics that you like to listen to, or if you would like to use this platform as a to present your work or best practice, do approach us and we will get you into our next meeting. Thank you very much. Thank you, everyone.
Thank you.